everyone. I'm Kirby. Again, I'm the other fellow. Okay, so this is a case of recurrent stricture in a patient with Crohn's disease. So the patient's a 44-year-old female with a past medical history of celiac disease and stricturing Crohn's. She underwent a small bowel resection and stricturoplasty in 2005, and she's currently off of therapy. So in December, she presented to our clinic with a 12-month history of intermittent stomach pain, distension, and emesis. She noted that it was worse with high-fiber foods. There were no other change in her bowel habits, no weight loss, and her last colonoscopy was in 2024 and was unremarkable. Unfortunately, we don't have the report, but that's what she was told. Regarding her history, the celiacs and the Crohn's, a little bit more of that operation. So it was exploratory laparotomy, 2 small bowel resections, and 3 stricturoplasties, and that was 20 years ago. Since then, she's had 3 C-sections and then a hysterectomy. No family history of IBD or GI malignancy, and only medication was Prozac. So after the onset of these symptoms, she established care with a local gastroenterologist who obtained an MRE. Play this here. So this showed a 1.9 centimeter distal ileal segment with wall thickening, hyperenhancement, and luminal narrowing consistent with stricture and active inflammation. Sorry, it's a little fuzzy. Okay, so our first questions for the panel. What is the role of repeat endoscopic evaluation in this patient, given her last colonoscopy was 11 months ago? Again, we don't know if they examined any or how much of the small bowel.
It is shocking to me why these patients continually undergo endoscopic evaluation when they don't get to the area that's diseased. So I don't know if she had an ileocolic resection or a small bowel resection, and it's clear and in my opinion, that the person does the colonoscopy, whether they get into the TR or not, there's no Crohn's disease, and then the patient's like, oh, Mike, I don't have Crohn's disease. And meanwhile, they're not looking in the right spot. And it's just fascinating that they'll just get colonoscopy after colonoscopy after colonoscopy, but they're not looking at the diseased area, which you need
but the point that
better imaging.
But this patient was not managed, right?
The patient wasn't managed at all.
No, because she had this stricturoplasty and then nothing happened. She was not on any
no
treatment,
therapy.
So she was lost to follow-up. So this is a
separate issue.
Terrible
The
example of
issue that she wasn't
no
treated
follow-up.
for.
Right,
Right.
exactly.
But so now how would you evaluate it at this point? There's a stricture on a scan. Can you tell where in the small bowel that is? I don't think you can.
The problem is, I don't think you're going to get there endoscopically unless you try to do a double balloon, But I think a standard colonoscopy is not going to help with this patient at all. So, right. But they come in with annual colonoscopies, right? And they're told everything looks, I know exactly why it's done, but it's not helpful to the management of the patient.
So where is a stricture?
It's in the distal
ileum.
Distal
Yes, sir.
ileum.
Yes, and she did not have an ileocolic resection.
Which can
before,
mean
just small
anything,
bowel.
by the way, when
Correct.
they say distal ileum.
Correct.
Okay.
Next question, next management options. Would you offer her medical therapy versus endoscopic dilation or upfront resection?
Sorry, I'm lost now. So where is the stricture, and did she get a new endoscopic evaluation?
She did not. Correct. 1.9 centimeters.
Yeah, so the problem is you have to be able to see if you can sort of,
Reach.
if there's upstream dilation, if you can get, a little more information about the nature of the stricture.
And you need biopsies.
But
So would you do an endoscopic colonoscopy, like whether it was double balloon or like trying to get to it after talking to radiology about where the stent is, or would you send her directly to surgery? What would be your approach?
how much weight has she lost?
No weight loss.
I forgot her clinical. I mean, there's a 99% chance this patient's going to need an operation, but
David, this is his favorite topic. David?
She has a small bowel cancer.
David?
Yes, Dr. Sacker?
Is this a recurrent stricture after 15 years of remission, or has she been sick the whole time?
We don't know.
Her symptoms started a year ago. She had been totally fine for 20 years. And then that we know of.
Develops a new stricture after 20-something years
Red
of
flag.
remission. I call it cancer until proven otherwise.
so
So just so it's clear,
right.
Dr. Sacker's been teaching that
Yes.
for
Red flag.
forever.
Look at his face.
Otherwise, no problem proving otherwise.
That is, that face.
I mean,
So with that being said, would you all agree to send her to surgery right away?
Yeah, I don't think you're going to do anything with a double balloon. First of all, she had 3 stricturoplasties.
Yeah.
So any one of them could be the one that's
It would be
giving her the symptoms.
super difficult to.
Yeah.
your questions in order, I would have scoped him again.
Yes.
Because I think if there was a clinical change, to be able to tell the surgeons at least, you know, you have healthy bowel, I think is important. If I didn't reach the stricture, to Jim's point, because the other mistake we see a lot, even a lot, is endoscopists have no idea how an ileocolic and anastomosis put back together. So they'll say they have strictures, and they're just looking at the blind part. They're not actually going. So I would do that, and then if I didn't reach the stricture, unless there was a reason I thought this patient had a very compromised bowel length, trying to even consider going by a double balloon and doing repeated endoscopic dilations that way is not efficient, and I probably would have sent to surgery.
Honestly, I think we have too high a threshold to do double balloon.
Right.
We have it, it's a very useful
Yeah.
tool in many parts of the world. They do it much more than we do. They're able to get there. You would have a better sense of what that is. You'd be able to biopsy it, and if it is a cancer, as it could be, you know, you might have a sense of what's there before you have it.
Bruce,
But
my
the
only
main
problem was she had 3 stricturoplasties. So my problem is, number one, they only see one of the
Only see
strictures.
one,
Right.
right.
So that sounds like, I'm not sure that's.
I think the main problem is that
Right.
any endoscopic evaluation, the risk of false negative is super high.
Well, I think the imaging was severely dilated.
Yes.
And my only, and I agree with you, and I love double balloon, and I still send a lot of people for it. I guess in this patient with that imaging and that history, I don't know how much it would change management, but it could. But yeah.
But just to clarify, Jumper, you mean false negative in terms of finding the lesion,
Yes.
or false negative in terms of you found something
Or finding
that
a
looks odd
cancer.
and you take samples?
Yes.
Because I'm more concerned about the
Yes.
sampling error.
Exactly.
Because I don't think you're going to necessarily see a cancer.
Yeah.
This is a problem because if you find something, okay, but if you don't find anything, so what?
Yeah, everything's fine. And then-
So in both cases, you need to send the patient to the surgeon.
Okay. All right. Okay. And then lastly, anything on imaging? I know it was a little yeah, we talked about that. Okay. All right. So she underwent an exploratory laparotomy, a lysis of adhesions, and a small bowel resection in January. So we encountered a short strictured segment of proximal ileum with chronically dilated small bowel upstream. After resection, approximately 235 centimeters of small bowel remained, and a Crohn S anastomosis was performed.
But that dilation was not seen on the imaging.
It was, yes, sir.
Oh.
Yes, sir. Yes, sir.
So why are you doing the CONOS? Oh, it's a good answer.
No, that's not. Yeah, not at all. That's not the case at all.
Dr. Michelasi show that it doesn't make a difference?
No, actually, there was a study presented at
He was
ECHO.
trying to say it decreases recurrence.
There is some data to suggest that there's decreased recurrence for
Right,
Crohn
right.
OS anastomosis, and so that's why we elected to do it in this patient who had already had a presumed stricture recurrence, but as we learned, it was not that. So that was why we elected to do Crohn OS.
Plus, it's fun.
And yes, sir.
Lots of suture.
And easier for our endoscopy colleagues. Yes, nice end-to-end anastomosis for you. Yes, yes. I've heard. I'm sorry. Okay, I won't go into too much detail on that. So the patient did great postoperatively. She was discharged home post-op day 3, but we were very surprised to find that she had invasive, moderately differentiated adenocarcinoma of the ileum at 3.6 centimeters in measurement, with background active Crohn's ileitis. They examined 25 lymph nodes, and they were all negative for carcinomas.
I'm surprised you found 25 lymph nodes in that.
Our pathologist did a great job. 25.
No, the association of the inflammation with the adenocarcinoma, what do you think about that?
Well, the cancers occur where there's inflammation.
Right, so, but like, do you see that? So like even patients with no Crohn's of a small bowel adenocarcinoma,
Yeah.
that area is usually inflamed.
They're always.
Always.
One of the few always is.
So that put her at T3N0. I'm sorry, what's that?
Sorry, Dr. Harpez, maybe you can comment on the pathology as well.
Yeah, we'll go.
So the right side is proximal. You can see that there's a gradual dilatation there. And then the small bowel looks like it's buckled. I mean, there's an anastomosis somewhere in there, and it's puckered. There's this like pocket. But in any case, the sections came from that area. There's another area down all the way at the end that might have been another stricturoplasty site. I am not sure. I asked the distal end. I asked the pathologist who handled it, and she herself wasn't sure. But in any event, the sections came from the sort of center of the specimen. Okay, and there you go. Okay, so on the left, you've got a full thickness section of the small intestine. On top, you see kind of a villiform lesion, which I'll show you at higher magnification. There's cancer, which is very hard to see at this magnification. And then in the mesentery, which is on the bottom, you see this mass of fibrous tissue, and I'll show you each of those. Okay, now on the right, you see those lymphoid aggregates. That's in the middle of the wall. Just typical Crohn's aggregative, lymphoid follicles. And then on the bottom, you're looking at the junction between the bowel and the fat. Again, you see multiple lymphoid aggregates. Now, if you go to the next slide, okay, so on the left, you see a villiform structure with atypical cells on the right. This is low-grade dysplasia, adenomatous type. There was no high-grade. This was all low-grade dysplasia. Next slide. Okay, and this was a very well-differentiated adenocarcinoma. Each of you have these beautifully well-formed glands with kind of either circular or amoeboid shapes, and very little of a reaction around them. If you look on the right, there's a little bit of a reaction around each of the glands, but we refer to this as the tubular-glandular type. It's a bona fide type of very low-grade adenocarcinoma. If it doesn't change, as if all your sections show this, then the prognosis is very good. But as you'll see in the next slide, if there are other areas that are higher grade, then that's what drives the prognostic feature. This area is moderately differentiated. You can see a few scattered glands in this mass of nerves and fibrous tissue. And just one more slide, I think. Okay, again, going back to the original slide, now a section from the mesentery. What you're looking at on the right are nerves infiltrated by cancer. So there was very impressive perineural, or intraneural actually, invasion. Okay, and there were 20-some lymph nodes. They were all negative, so stage 2A. I don't know if there are any other sections. I think that's it. Oh, yes. So here's some lymph nodes. And where the circles are, we found some granulomas. Actually, that's the only place we found granulomas in the specimen.
So in terms of the surgery you did, to Bruce's point, if you had had a biopsy and you knew it was an adenocarcinoma, would the surgery have been very different? Like, was there a high chance that we did like a bad cancer surgery for this patient? Or?
I mean, Kirby, you sound like you.
I don't think so. I mean, we had great negative margins. We had a great lymph node harvest. The only thing we would have done was stage her preoperatively.
Probably go lower in the mesentery, right?
I mean, yeah, maybe. Yeah, that's true. That's true. Yeah, we got 25 nodes though. We got 25 nodes. Yeah. Yeah.
So it's always good to assess the total length of small bowel remaining.
Yeah.
And when someone had long-standing history of Crohn's like this, it's always a good idea to take enough mesentery rather than sticking close to the bowel.
Yeah. Yeah.
And also, it's much safer and easier to avoid the area right adjacent, mesentery right adjacent to the bowel.
Yeah.
Far away.
That's true.
Easier and safer.
That area is
That area is thick and it can
Yeah. Yeah.
So I'm kind of curious how you guys, because with the CONOS, you have to stay like right underneath.
Exactly. This
How did you
is
do that?
completely contradictory.
Modified CONOS.
With the mesenteric excision, that's exactly opposite.
Yeah. Yeah.
Yeah.
So the purpose, to Dr. Pleats's point, the whole purpose of the CONOS is you want to take as little mesentery as possible and stay close to the bowel wall to preserve neurovascular supply. We took a little more mesentery than you would typically take in a traditional CONOS.
So one question, was this adjacent to or within a prior stricturoplasty site? Was it just above one?
I
or-
think it was in a prior stricture
In a
plasty
prior
set.
stricture
Yeah, and that's
plasty
what
set.
Dr. Steinhagen was leaning towards too, but it was kind of hard to tell intraoperatively.
Well, if they saw the anastomosis, like the suture line from
No, so
before.
you couldn't tell.
He couldn't tell. Yeah.
Some kind of surgical site.
Well, it almost makes sense that it would be in the area of active disease that was never resected. So it was chronic active inflammation that was never resected that eventually.
Usually in a stricturoplasty, there's a reduction or elimination of inflammation within the stricturoplasty itself. So that, I would have presumed it would have been right above it.
So just briefly, she had a port placed last week, and then she's going to start adjuvant chemotherapy in the upcoming weeks. So my very last question, or I guess two short questions, is what would be your recommendation for medical management for her moving forward? And then how would you survey this patient after chemotherapy?
I don't know that she needs Crohn's management necessarily. I think you could argue to survey. I mean, she had a long time. The problem is we just don't know. But otherwise, look fine. And then I think how you survey, I mean, I think then you probably would say you
Survey
might
her
try
like
to
a
push.
cancer patient.
Exactly.
Basically.
You have to get there.
Right. I'll say that the double balloons from below, and again, I do send a lot of people, we do not get very far. You know, oftentimes I feel like they, I get 20, 30 centimeters. From above,
You
I
should
think it's
get
very
more than that.
effective. I know.
Effective double balloon should be
Yeah.
anterograde, retrograde, and meeting in the middle.
I mean, we should have them here because I think the anterograde works great, right? And I think we get really deep. But retrograde, I mean, they still have to, especially in our bad Crohn's patients. It's very difficult sometimes to position the scope. There's a lot of scar tissue. You know, they don't often get as deep as I think I would love them.
So the big question here for us is thinking, especially in patients who are otherwise completely asymptomatic, many of them are just going to disappear. What is a surveillance protocol for somebody who had stricturoplasty? Should you be more concerned about a patient with stricturoplasty than having had just a primary resection? Because that's the anxiety. It's like, are we leaving chronically inflamed tissue that then, to your point, cannot be surveilled appropriately?
The most likely thing is you're not going to prevent small bowel cancer in Crohn's disease.
Okay.
That's the most likely answer.
Actually, the most effective way is to treat the Crohn's,
metacrohn.
which
Right.
you didn't.
So I actually would probably give her an IL-23 blocker after she's done with her, because she's still only 45. So I would probably give her,
And that should be quite safe in terms of
Safe,
the
yes.
adenocarcinoma.
So there's no role for MREs, like once a year, every other year? just
Problem
for
is you're
sure
gonna
to
see-
know?
You'll do it, but it's not, don't think that you're really.
Change it.
What about the activity of Crohn's disease during chemotherapy? Is there any change in activity or symptoms?
It really depends on the chemotherapy that they're going to give her. Generally, the literature shows that patients with Crohn's disease and UC don't tolerate chemotherapy as well as non-IBD patients. They tend to have more GI side effects, less tolerance of normal dosing overall. So then they tend to be undertreated. You know, we're talking about standard chemotherapy of the historic past, not immunotherapy. Immunotherapy is a whole other thing because that could also trigger their IBD.
so you have to be very careful in patients who you're giving immunotherapy to, in terms of much higher recurrence rate of their IBD. And you just have to be cognizant of it and treat it best you can. And they might not be able to tolerate the immunotherapy.
Thank you, everyone. That's all we have.
Oh, yeah, we should have the surgeons more often.
Well, that's right.